Sedative hypnotic anxiolytic drugs. A clinical perspective. Sedative hypnotic anxiolytic, SHA, drugs are a class of medications that act on the central nervous system, CNS, to produce a calming effect, induce sleep, or reduce anxiety. They are widely used in clinical practice to manage various conditions, including insomnia, anxiety disorders, and preoperative sedation. Mechanism of action. The primary mechanism of action for most SHA drugs involves the G-aminobutyric acid, GABA, neurotransmitter system. GABA is the primary inhibitory neurotransmitter in the brain, and it plays a crucial role in regulating neuronal excitability. SHA drugs enhance the inhibitory effects of GABA by binding to specific receptors on neurons, leading to increased chloride ion influx and hyperpolarization of the cell membrane. This hyperpolarization makes it more difficult for neurons to generate action potentials, resulting in a calming effect. Classification: SHA drugs can be broadly classified into several categories based on their chemical structure and mechanism of action. Benzodiazepines. This is the most widely used class of SHA drugs. They include drugs such as diazepam, lorazepam, alprazolam, and clonazepam. Benzodiazepines have a high therapeutic index, meaning that they have a wide margin of safety between therapeutic and toxic doses. Non-benzodiazepine hypnotics, Z-drugs. These drugs, such as zolpidem, zaloplan, and azapaclone, are structurally related to benzodiazepines but have a different mechanism of action. They selectively target the GABA-A receptor complex, leading to hypnotic effects without significant anxiolytic or muscle relaxant properties. Barbiturates. Although once widely used, barbiturates have largely been replaced by safer alternatives due to their high potential for abuse and overdose. They act by potentiating GABA-A receptor activity and directly inhibiting neuronal activity. Over-the-counter, OTC, sleep aids. These medications, such as diphenhydramine and doxylamine succinate, are antihistamines with sedative properties. They are generally safe for short-term use, but can cause daytime drowsiness and cognitive impairment. Clinical uses: SHA drugs are used to treat a variety of conditions, including insomnia. SHA drugs can be helpful for short-term treatment of insomnia, especially in cases of difficulty falling asleep or maintaining sleep. Anxiety disorders. Benzodiazepines are effective in managing anxiety disorders such as generalized anxiety disorder, panic disorder, and social anxiety disorder. Seizure disorders. Some SHA drugs, such as clonazepam and diazepam, are used to treat certain types of seizures, including status epilepticus. Muscle spasms. Benzodiazepines can relax muscles and are sometimes used to treat muscle spasms associated with conditions such as back pain and spasticity. Preoperative sedation. Benzodiazepines, such as midazolam, are commonly used for premedication before surgery to reduce anxiety and induce sedation. Adverse effects. HA drugs can cause a variety of adverse effects, including drowsiness and sedation. This is a common side effect of SHA drugs, especially at higher doses. Impaired cognitive function. SHA drugs can impair attention, memory, and coordination. Dizziness and lightheadedness. These symptoms can increase the risk of falls and accidents. Paradoxical excitement. In some individuals, especially the elderly, SHA drugs can cause agitation, restlessness, and confusion. Tolerance and dependence. Prolonged use of SHA drugs can lead to tolerance, meaning that higher doses are needed to achieve the same effect. Dependence can also occur, leading to withdrawal symptoms upon discontinuation of the medication. Respiratory depression. High doses of SHA drugs, especially barbiturates, can depress breathing and lead to respiratory failure. Alcohols. Central nervous system pharmacology. Alcohols, particularly ethanol, are widely consumed substances with significant effects on the central nervous system, CNS. Understanding their pharmacological actions is crucial for healthcare professionals in managing alcohol-related disorders and providing appropriate care to patients. Pharmacokinetics of ethanol. Absorption. Ethanol is readily absorbed from the gastrointestinal tract, primarily in the stomach and small intestine. The rate of absorption can be influenced by various factors, including gastric emptying time, food intake, and the concentration of alcohol in the beverage. Distribution. Once absorbed, ethanol is rapidly distributed throughout the body's water compartments, including the brain. Metabolism. The primary site of ethanol metabolism is the liver. The enzyme alcohol dehydrogenase, ADH, converts ethanol to acetaldehyde, which is then further metabolized by aldehyde dehydrogenase, ALDH, to acetate. Elimination. Ethanol is primarily eliminated through the lungs, kidneys, and sweat glands. The rate of elimination is relatively constant and is influenced by factors such as liver function and genetic variations in enzyme activity. Pharmacodynamic effects of ethanol. Ethanol exerts its effects on the CNS by interacting with various neurotransmitter systems. GABAergic system. Ethanol enhances the inhibitory effects of GABA, the primary inhibitory neurotransmitter in the brain. This leads to increased chloride ion influx, hyperpolarization of neurons, and reduced neuronal excitability. Glutamatergic system. Ethanol inhibits glutamate release, a major excitatory neurotransmitter. This contributes to the sedative and hypnotic effects of alcohol. Dopaminergic system. Ethanol stimulates the release of dopamine, a neurotransmitter involved in reward and pleasure. This may contribute to the reinforcing effects of alcohol and its potential for addiction. Clinical effects of ethanol. The clinical effects of ethanol vary depending on the blood alcohol concentration, BAC, low to moderate BAC. At low to moderate BAC levels, ethanol produces a range of effects, including euphoria, reduced anxiety, impaired judgment, decreased motor coordination, slurred speech. High BAC. At high BAC levels, ethanol can lead to more severe effects such as severe sedation, loss of consciousness, respiratory depression, coma, death. Alcohol-related disorders. Chronic alcohol abuse can lead to a variety of health problems, including alcohol use disorder. This is a chronic relapsing disorder characterized by compulsive alcohol use, loss of control over drinking, and negative consequences. Alcohol-induced liver disease. Excessive alcohol consumption can damage the liver, leading to conditions such as fatty liver disease, alcoholic hepatitis, and cirrhosis. Pancreatitis. Alcohol can cause inflammation of the pancreas, leading to severe abdominal pain, nausea, vomiting, and potential complications. Cardiovascular disease. Chronic alcohol abuse can increase the risk of heart disease, stroke, and hypertension. Neurological disorders. Excessive alcohol consumption can damage the brain, leading to cognitive impairment, memory loss, and neurodegenerative disorders. Treatment of alcohol-related disorders. The treatment of alcohol-related disorders involves a multidisciplinary approach, including detoxification. This involves medically supervised withdrawal from alcohol to manage withdrawal symptoms, such as anxiety, tremors, seizures, and delirium tremens. Pharmacotherapy. Medications such as disulfiram, naltrexone, and ecamprosate can be used to reduce alcohol craving and prevent relapse. Psychotherapy. Cognitive behavioral therapy and other forms of psychotherapy can help individuals develop coping skills. Drugs used for depression, bipolar disorder, and ADHD. A clinical perspective. This section will delve into the pharmacological agents commonly employed to treat depression, bipolar disorder, and attention deficit hyperactivity disorder, ADHD. These medications primarily target neurotransmitter systems in the brain, particularly those involving serotonin, norepinephrine, and dopamine. Depression. 1. Selective serotonin reuptake inhibitors, SSRIs. Mechanism of action. SSRIs block the reuptake of serotonin, increasing its availability in the synaptic cleft. Clinical uses: major depressive disorder, obsessive compulsive disorder, panic disorder, social anxiety disorder, and post-traumatic stress disorder. Common examples: fluoxetine, sertraline, paroxetine, fluvoxamine, and escitalopram. Adverse effects: sexual dysfunction, nausea, headache, insomnia, and weight gain. 2. Serotonin norepinephrine reuptake inhibitors, SNRIs. Mechanism of action: SNRIs inhibit the reuptake of both serotonin and norepinephrine. Clinical uses: major depressive disorder, generalized anxiety disorder, and fibromyalgia. Common examples: venlafaxine, duloxetine, desvenlafaxine, and levomilnacipran. Adverse effects: nausea, headache, insomnia, increased blood pressure, and sexual dysfunction. 3. Norepinephrine dopamine reuptake inhibitors, NDRIs. Mechanism of action: NDRIs inhibit the reuptake of both norepinephrine and dopamine. Clinical uses: major depressive disorder and attention deficit hyperactivity disorder, ADHD. Common examples: bupropion. Adverse effects: insomnia, agitation, dry mouth, and seizures at high doses. 4. Tricyclic antidepressants, TCAs. Mechanism of action: TCAs inhibit the reuptake of both serotonin and norepinephrine, as well as blocking histamine and acetylcholine receptors. Clinical uses: major depressive disorder, chronic pain, and neuropathic pain. Common examples: amitriptyline, nortriptyline, imipramine, and desipramine. Adverse effects: anticholinergic side effects, dry mouth, constipation, blurred vision, sedation, cardiac toxicity, and weight gain. 5. Monoamine oxidase inhibitors, MAOIs. Mechanism of action: MAOIs inhibit the enzyme monoamine oxidase, which breaks down neurotransmitters like serotonin, norepinephrine, and dopamine. Clinical uses: treatment-resistant depression, atypical depression, and panic disorder. Common examples: phenelzine, tranylcypromine, and isocarboxazid. Adverse effects: hypertensive crisis with tyramine-containing foods, cheese, wine, aged meats, sedation, and sexual dysfunction. Bipolar disorder 1. Mood stabilizers, lithium. Exact mechanism of action is unclear, but it may influence various neurotransmitter systems. Clinical uses: bipolar disorder, acute mania, and bipolar depression. Adverse effects: hypothyroidism, kidney dysfunction, tremor, and weight gain. Anticonvulsants: valproic acid, carbamazepine, and lamotrigine. Atypical antipsychotics: risperidone, olanzapine, quetiapine, and ziprasidone. Attention deficit hyperactivity disorder, ADHD. 1. Stimulants: methylphenidate increases dopamine and norepinephrine levels in the prefrontal cortex. Amphetamines: similar mechanism of action to methylphenidate. Clinical uses: ADHD, narcolepsy, and chronic fatigue syndrome. Adverse effects: insomnia, decreased appetite, headache, and cardiovascular side effects. 2. Non-stimulant medications: atomoxetine, selective norepinephrine reuptake inhibitor, alpha-E2 adrenergic agonists, clonidine and guanfacine. Clinical uses: ADHD. Adverse effects: sedation, dry mouth, and hypotension. Important considerations: pharmacokinetic and pharmacodynamic interactions. Be aware of potential interactions between psychiatric medications and other drugs, including over-the-counter medications. Monitoring. Regular monitoring of blood levels, electrocardiograms, and clinical assessments is essential. Drugs used for Parkinson's disease and psychosis. A clinical perspective. Parkinson's disease. Parkinson's disease is a neurodegenerative disorder characterized by the progressive loss of dopamine-producing neurons in the substantia nigra. This loss of dopamine leads to a dopamine deficiency in the striatum, resulting in motor symptoms such as tremor, rigidity, bradykinesia, and postural instability. Pharmacological treatment of Parkinson's disease. Dopamine replacement therapy. Levodopa, the most effective drug for treating the motor symptoms of Parkinson's disease. It is a precursor to dopamine and is converted to dopamine in the brain. Carbidopa, an inhibitor of peripheral decarboxylase, which prevents the conversion of levodopa to dopamine in the periphery, increasing its bioavailability in the brain. Combination. Therapy. Levodopa is often combined with carbidopa to enhance its efficacy and reduce side effects. Dopamine agonists, ergot, derivatives, bromocriptine and pergolide. Non-ergot derivatives, ropinirole, pramipexole, rodigatine. Mechanism of action: directly stimulate dopamine receptors in the brain, mimicking the effects of dopamine. Clinical use: early-stage Parkinson's disease and as adjunctive therapy to levodopa. MAO-B inhibitors. Selegiline and rasogoline inhibit the enzyme monoamine oxidase B, which breaks down dopamine. Clinical use: early-stage Parkinson's disease and as adjunctive therapy to levodopa. CoMT inhibitors, entacapone and opicapone, inhibit catechol O methyltransferase, an enzyme that breaks down levodopa. Clinical use: adjunctive therapy to levodopa to prolong its effects. Anticholinergic drugs. Benztropine and trihexyphenidyl block acetylcholine receptors, reducing tremor and rigidity. Clinical use: primarily used to treat tremor and drug-induced dyskinesia. Psychosis. Psychosis is a mental disorder characterized by a loss of contact with reality, often manifesting as delusions, hallucinations, and disorganized thinking. Pharmacological treatment of psychosis. Antipsychotic drugs. Typical antipsychotics, first generation: haloperidol, fluphenazine, chlorpromazine, block dopamine D2 receptors. Clinical use: primarily used to treat positive symptoms of schizophrenia, such as hallucinations and delusions. Adverse effects. Extrapyramidal side effects: EPS, tardive dyskinesia, neuroleptic malignant syndrome. Atypical antipsychotics, second generation. Risperidone, olanzapine, quetiapine, clozapine, aripiprazole block both dopamine D2 and serotonin 5-HT2A receptors. Clinical use: treatment of both positive and negative symptoms of schizophrenia, as well as bipolar disorder and other psychotic disorders. Adverse effects: metabolic side effects, weight gain, hyperglycemia, dyslipidemia, sedation, and increased prolactin levels. Key considerations for pharmacological treatment. Individualized treatment. Treatment plans should be tailored to the specific needs of each patient, considering factors such as symptom severity, comorbidities, and patient preferences. Monitoring. Regular monitoring of clinical response, adverse effects, and laboratory tests is essential. Polypharmacy. Avoid polypharmacy whenever possible, as it can increase the risk of adverse effects and drug interactions. Non-pharmacological interventions. Psychotherapy, cognitive behavioral therapy, and social skills training can complement pharmacological treatment. Patient education. Educate patients about their medications, including potential side effects, adherence, and the importance of regular follow-up. By understanding the mechanisms of action, clinical uses, and adverse effects of these medications, healthcare providers can make informed decisions about their appropriate use in the management of Parkinson's disease and psychosis. Anticonvulsant drugs. A clinical perspective. Anticonvulsant drugs, also known as anti-seizure medications, are a class of medications used to prevent or reduce the frequency and severity of seizures. Seizures are abnormal electrical discharges in the brain that can cause a variety of symptoms, including involuntary muscle contractions, loss of consciousness, and sensory disturbances. Mechanisms of action. Anticonvulsants work through various mechanisms, including inhibition of sodium channel function. Drugs like phenytoin, carbamazepine, and lamotrigine block sodium channels, reducing neuronal excitability. Enhancement of GABAergic inhibition. Drugs like benzodiazepines, e.g. clonazepam, diazepam, and barbiturates, e.g. phenobarbital, enhance the inhibitory effects of GABA, the primary inhibitory neurotransmitter in the brain. Blockade of calcium channels. Drugs like gabapentin and pregabalin reduce calcium influx into neurons, decreasing neurotransmitter release. Other mechanisms. Some drugs, like valproic acid, have multiple mechanisms of action, including inhibition of sodium channels, enhancement of GABAergic inhibition, and modulation of other neurotransmitter systems. Clinical uses. Anticonvulsant drugs are primarily used to treat epilepsy, a neurological disorder characterized by recurrent seizures. However, they are also used for other conditions, such as bipolar disorder. Valproic acid and lamotrigine are effective in treating bipolar disorder. Neuropathic pain. Gabapentin and pregabalin are used to treat neuropathic pain conditions like diabetic neuropathy and postherpetic neuralgia. Migraine headaches. Valproate and topiramate can be used to prevent migraine headaches. Anxiety disorders. Benzodiazepines, such as clonazepam and diazepam, are used to treat anxiety disorders. Common anticonvulsant drugs. Phenytoin, primarily used for focal seizures. Adverse effects. Gingival hyperplasia, hirsutism, and Stevens-Johnson syndrome. Carbamazepine, effective for focal seizures and generalized tonic-clonic seizures. Adverse effects. Stevens-Johnson syndrome, aplastic anemia, and hyponatremia. Valproic acid, broad-spectrum anticonvulsant used for various seizure types, including generalized tonic-clonic, focal, and absent seizures. Adverse effects. Weight gain, hair loss, tremor, and hepatotoxicity. Lamotrigine, effective for focal seizures and generalized tonic-clonic seizures, as well as bipolar disorder. Adverse effects. Rash, including Stevens-Johnson syndrome. Gabapentin and pregabalin, primarily used for neuropathic pain but also effective for certain types of seizures. Adverse effects. Dizziness, sedation, and weight gain. Benzodiazepines, used for acute seizures, status epilepticus, and anxiety disorders. Adverse effects. Sedation, respiratory depression, and dependence. Barbiturates, used for status epilepticus and refractory seizures. Adverse effects. Sedation, respiratory depression, and dependence. Important considerations. Therapeutic drug monitoring. Regular monitoring of blood levels is essential to optimize therapy and minimize adverse effects. Polypharmacy. Avoid polypharmacy whenever possible, as it can increase the risk of adverse effects and drug interactions. Patient education. Educate patients about their medications, including potential side effects, adherence, and the importance of regular follow-up. Non-pharmacological interventions, lifestyle modifications such as stress management and regular sleep can complement pharmacological therapy. By understanding the mechanisms of action, clinical uses, and adverse effects of anticonvulsant drugs, healthcare providers can make informed decisions about their appropriate use in the management of epilepsy and other neurological disorders. Drugs used in anesthesia. A clinical perspective. Anesthesia is a state of controlled loss of sensation or awareness, induced for medical procedures. Anesthetic drugs are used to achieve this state, allowing for pain-free and safe surgical interventions. These drugs target the central nervous system, CNS, to produce a variety of effects, including sedation, hypnosis, analgesia, and muscle relaxation. General anesthetics. General anesthetics induce a reversible loss of consciousness, amnesia, and analgesia. They are typically administered intravenously or inhaled. Inhaled anesthetics. Volatile anesthetics. Isoflurane, sevoflurane, desflurane. These agents are inhaled gases that rapidly enter and exit the brain, allowing for precise control of anesthesia. Mechanism of action. They enhance the inhibitory effects of GABA and reduce the excitatory effects of glutamate. Adverse effects. Respiratory depression, hypotension, and cardiac arrhythmias. Intravenous anesthetics. Propofol, a short-acting anesthetic that produces rapid onset and offset of sedation and hypnosis. Mechanism of action. Enhances GABAergic inhibition. Adverse effects. Hypotension, respiratory depression, and pain on injection. Thiopental, a barbiturate that induces rapid loss of consciousness. Mechanism of action. Enhances GABAergic inhibition. Adverse effects. Respiratory depression, hypotension, and cardiovascular instability. Ketamine, a dissociative anesthetic that produces a state of unconsciousness and analgesia. Mechanism of action. Blocks NMDA receptors. Adverse effects. Emergence delirium, hallucinations, and increased intracranial pressure. Local anesthetics. Local anesthetics block nerve conduction, preventing the transmission of pain signals. They are commonly used for regional anesthesia, such as spinal or epidural anesthesia, as well as for topical anesthesia. Amides. Lidocaine, bupivacaine, ropivacaine. These agents are widely used for their long duration of action and low toxicity. Mechanism of action. Blocks sodium channels, preventing the generation and propagation of action potentials. Esters. Procaine, benzocaine. These agents are less commonly used due to their shorter duration of action and higher risk of allergic reactions. Muscle relaxants. Muscle relaxants are used to facilitate surgical procedures by inducing paralysis of skeletal muscles. Depolarizing muscle relaxants. Succinylcholine binds to nicotinic acetylcholine receptors, causing depolarization and paralysis. Adverse effects. Hyperkalemia, muscle pain, and malignant hyperthermia. Non-depolarizing muscle relaxants. Rocuronium, vecuronium, cisatracurium. These agents competitively block nicotinic acetylcholine receptors, preventing muscle contraction. Adverse effects. Prolonged neuromuscular blockade, respiratory depression, and cardiovascular instability. Adjunctive drugs. Adjunctive drugs are used to enhance the effects of anesthetics or to manage specific physiological responses during surgery. Opioids. Fentanyl, sufentanil. These drugs provide analgesia and sedation. Adverse effects. Respiratory depression, constipation, and nausea. Benzodiazepines. Midazolam, used for sedation and anxiolysis. Adverse effects. Respiratory depression, amnesia, and hypotension. Important considerations. Patient assessment. A thorough preoperative assessment is crucial to identify risk factors and optimize anesthetic management. Monitoring. Continuous monitoring of vital signs, including heart rate, blood pressure, oxygen saturation, and end tidal CO2, is essential. Adverse effects. Anesthetists must be prepared to manage potential adverse effects such as respiratory depression, hypotension, and cardiac arrhythmias. Postoperative care. Close monitoring is required in the postoperative period to manage pain, nausea, and other. Opioid analgesics. A clinical perspective. Opioid analgesics are a class of drugs that mimic the actions of endogenous opioids, such as endorphins and enkephalins, to produce analgesia. They are widely used for the management of moderate to severe pain. Mechanism of action. Opioids primarily act on opioid receptors in the central nervous system, CNS. These receptors are located in various brain regions, including the spinal cord, brainstem, and limbic system. By binding to these receptors, opioids inhibit the transmission of pain signals and produce analgesia. Classification of opioids. Opioids can be classified into two main categories. Natural opioids. Morphine, a potent opioid derived from the opium poppy plant. It is used for the management of severe pain, including postoperative pain, cancer pain, and end-of-life care. Codeine, a weaker opioid often used for mild to moderate pain. It is commonly combined with other analgesics, such as acetaminophen or ibuprofen. Synthetic opioids. Strong opioids. Fentanyl, a potent synthetic opioid that is 50 to 100 times more potent than morphine. It is used for the management of severe pain, especially in the perioperative setting. Oxycodone, a semi-synthetic opioid that is similar in potency to morphine. It is commonly used for the management of moderate to severe pain. Hydrocodone, a semi-synthetic opioid that is less potent than oxycodone. It is often combined with acetaminophen or ibuprofen. Weak opioids. Tramadol, a synthetic opioid that has both opioid and non-opioid mechanisms of action. It is used for the management of moderate pain. Clinical uses of opioids. Opioids are used to treat a variety of pain conditions, including acute pain, postoperative pain, trauma, and acute injury, chronic pain, cancer pain, neuropathic pain, and chronic musculoskeletal pain. Procedural pain, pain associated with medical procedures such as endoscopy and surgery. Adverse effects of opioids. Opioids can cause a number of adverse effects, including constipation, a common side effect of opioid use, nausea and vomiting, particularly common with initial opioid use. Sedation and drowsiness can impair cognitive function and motor coordination. Respiratory depression, a serious adverse effect that can lead to respiratory failure and death. Tolerance and dependence. Prolonged use of opioids can lead to tolerance, requiring higher doses to achieve the same analgesic effect. Dependence can also occur, leading to withdrawal symptoms when the medication is stopped. Important considerations. Patient assessment. A thorough assessment of pain severity and underlying medical conditions is essential before initiating opioid therapy. Risk-benefit assessment. The potential benefits of opioid therapy must be weighed against the risks of adverse effects and addiction. Non-pharmacological interventions. Non-pharmacological interventions, such as physical therapy, occupational therapy, and cognitive behavioral therapy, can complement opioid therapy. Pain management plans. Develop comprehensive pain management plans that include both pharmacological and non-pharmacological interventions. Monitoring. Close monitoring of patients receiving opioid therapy is essential to identify and manage adverse effects. By understanding the mechanisms of action, clinical uses, and adverse effects of opioids, healthcare providers can make informed decisions about their appropriate use in the management of pain. It is important to use opioids judiciously and to be aware of the risks associated with their use. Drugs of abuse. A clinical perspective. Drugs of abuse are substances that are taken for non-medical purposes, often to alter mood, perception, or consciousness. These substances can have significant negative impacts on physical and mental health, leading to addiction, overdose, and other serious consequences. Common drugs of abuse. Stimulants. Cocaine, a potent stimulant that blocks the reuptake of dopamine, norepinephrine, and serotonin. Clinical effects. Euphoria, increased energy, reduced appetite, and insomnia. Adverse effects. Cardiovascular problems, including heart attack and stroke, seizures, psychosis, and addiction. Amphetamines, stimulants that increase the release of dopamine and norepinephrine. Clinical effects. Euphoria, increased alertness, and decreased fatigue. Adverse effects. Anxiety, insomnia, psychosis, and addiction. Methamphetamine, a highly addictive stimulant that can cause severe neurological damage. Depressants. Alcohol, a central nervous system depressant that inhibits neuronal activity. Clinical effects. Euphoria, relaxation, impaired judgment, and motor coordination. Adverse effects. Liver damage, pancreatitis, cardiovascular disease, and addiction. Benzodiazepines, a class of drugs used to treat anxiety and insomnia. Clinical effects. Sedation, muscle relaxation, and amnesia. Adverse effects. Respiratory depression, addiction, and cognitive impairment. Barbiturates, a class of drugs that depress the central nervous system. Clinical effects. Sedation, hypnosis, and anesthesia. Adverse effects. Respiratory depression, coma, and death. Opioids. Heroin, a highly addictive opioid that binds to opioid receptors in the brain, producing euphoria and pain relief. Clinical effects. Euphoria, sedation, and analgesia. Adverse effects. Respiratory depression, addiction, and overdose. Prescription opioids. Opioids prescribed for pain management such as oxycodone, hydrocodone, and fentanyl. Clinical effects. Pain relief and sedation. Adverse effects. Respiratory depression, addiction, and overdose. Hallucinogens. LSD, lysergic acid diethylamide, a powerful hallucinogen that alters perception and thought processes. Clinical effects. Visual hallucinations, altered sense of time, and intense emotional experiences. Adverse effects. Anxiety, paranoia, and flashbacks. Psilocybin mushrooms, a hallucinogenic fungus that contains psilocybin, a psychedelic compound. Clinical effects similar to LSD, including visual hallucinations and altered consciousness. Adverse effects. Anxiety, paranoia, and flashbacks. Cannabinoids. Marijuana, a plant that contains THC, tetrahydrocannabinol, the primary psychoactive compound. Clinical effects. Euphoria, relaxation, and altered perception. Adverse effects. Impaired cognitive function, respiratory problems, and addiction. Mechanisms of action. Drugs of abuse exert their effects by altering the function of neurotransmitter systems in the brain. Common mechanisms of action include increased neurotransmitter release. Stimulants like cocaine and amphetamines increase the release of dopamine, leading to feelings of euphoria and increased energy. Inhibition of neurotransmitter reuptake. Cocaine and amphetamines also block the reuptake of dopamine, prolonging its effects. Activation of neurotransmitter receptors. Opioids bind to opioid receptors, while hallucinogens and cannabinoids activate specific receptors in the brain. Inhibition of neurotransmitter release. Alcohol and benzodiazepines inhibit the release of excitatory neurotransmitters, leading to sedation and relaxation. Treatment of drug abuse. Treatment for drug abuse often involves a combination of pharmacological and psychological therapies. A comprehensive list of CNS drugs, a clinical perspective. This section provides a comprehensive overview of various drugs that target the central nervous system, CNS, encompassing a wide range of therapeutic applications, from treating neurological disorders to managing psychiatric conditions. Antipsychotics. Typical antipsychotics, first generation. Haloperidol, fluphenazine, chlorpromazine. Primarily used for positive symptoms of schizophrenia, hallucinations, delusions. Adverse effects. Extrapyramidal side effects, EPS. Tardive dyskinesia, neuroleptic malignant syndrome. Atypical antipsychotics, second generation. Risperidone, olanzapine, quetiapine, clozapine, aripiprazole treat both positive and negative symptoms of schizophrenia, bipolar disorder, and other psychotic disorders. Adverse effects. Metabolic side effects, weight gain, hyperglycemia, dyslipidemia, sedation, and increased prolactin levels. Antidepressants, selective serotonin reuptake inhibitors, SSRIs. Fluoxetine, sertraline, paroxetine, fluvoxamine, escitalopram, used for major depressive disorder, OCD, panic disorder, social anxiety disorder, and PTSD. Adverse effects. Sexual dysfunction, nausea, headache, insomnia, and weight gain. Serotonin norepinephrine reuptake inhibitors, SNRIs. Venlafaxine, duloxetine, desvenlafaxine, levomilnacipran. Used for major depressive disorder, generalized anxiety disorder, and fibromyalgia. Adverse effects. Nausea, headache, insomnia, increased blood pressure, and sexual dysfunction. Norepinephrine dopamine reuptake inhibitors, NDRIs. Bupropion, used for major depressive disorder and ADHD. Adverse effects. Insomnia, agitation, dry mouth, and seizures at high doses. Tricyclic antidepressants, TCAs. Amitriptyline, nortriptyline, imipramine, disipramine, used for major depressive disorder, chronic pain, and neuropathic pain. Adverse effects. Anticholinergic side effects, dry mouth, constipation, blurred vision, sedation, cardiac toxicity, and weight gain. Monoamine oxidase inhibitors, MAOIs. Phenelzine, tranylcypromine, isocarboxazid. Used for treatment-resistant depression, atypical depression, and panic disorder. Adverse effects. Hypertensive crisis with tyramine-containing foods, sedation, and sexual dysfunction. Anxiolytics and hypnotics. Benzodiazepines. Diazepam, lorazepam, alprazolam, clonazepam. Used for anxiety disorders, insomnia, and seizures. Adverse effects. Sedation, respiratory depression, and dependence. Non-benzodiazepine hypnotics, Z-drugs. Zolpidem, Zaloplan, Isopoquone, used for short-term treatment of insomnia. Adverse effects. Somnambulism, confusion, and daytime drowsiness. Anticonvulsants. Phenytoin, used for focal seizures. Adverse effects. Gingival hyperplasia, hirsutism, and Stevens-Johnson syndrome. Carbamazepine, effective for focal seizures and generalized tonic-clonic seizures. Adverse effects. Stevens-Johnson syndrome, aplastic anemia, and hyponatremia. Valproic acid, broad-spectrum anticonvulsant used for various seizure types. Adverse effects. Weight gain, hair loss, tremor, and hepatotoxicity. Lamotrigine, effective for focal seizures and generalized tonic-clonic seizures, as well as bipolar disorder. Adverse effects. Rash, including Stevens-Johnson syndrome. gabapentin and pregabalin, used for neuropathic pain and certain types of seizures. Adverse effects: dizziness, sedation, and weight gain. Opioid analgesics: morphine, a potent opioid used for severe pain. Adverse effects: constipation, respiratory depression, and addiction. Codeine, a weaker opioid often combined with other analgesics. Adverse effects: constipation, nausea, and drowsiness. Fentanyl, a potent synthetic opioid used for severe pain.